Okay, let's dive right into this explainer. Today, we're uncovering the global fight against superbugs by bridging those massive macro-level strategies with actual cellular-level science. It's a truly fascinating intersection. We're going to explore how sweeping decisions made at the global public health level directly tie into the microscopic behavior of bacteria inside the human body. This isn't just about memorizing a list of drug names, right? It's about really understanding the logic behind how we deploy our most critical medical weapons. So, what's the actual core problem we're facing? Well, it's antimicrobial resistance, or AMR. And honestly, it's a literal evolutionary arms race. Every single time we use an antibiotic, bacteria get a chance to learn, adapt, and basically outsmart it. So how do we stop them? The answer relies on extreme strategic discipline, knowing exactly when to use a light touch, when you need to bring in the heavy hitters, and understanding the precise cellular timing of how these drugs actually shut bacteria down. Here's our roadmap for today. We'll start with the WHO Aware System, break down the Access Watch and Reserve groups, and then wrap up by looking at the post-antibiotic effect and our dosing rules. All right, jumping into Section 1, the WARE system, our global antibiotic triage. Moving to Section 2, Access, the green zone, which is our baseline defense. Here is the absolute crucial point. This low-risk group really needs to account for the vast majority of antibiotics prescribed globally. We're talking a WHO target of at least 70% of all use. These are narrow-spectrum antibiotics, so think of them like a sniper rifle instead of a shotgun. They specifically target a limited range of common bacteria, which inherently carries a much, much lower risk of triggering widespread resistance. Hitting that 70% mark is a fundamental pillar of global health security.
You're probably going to recognize a bunch of our go-to Access medications. They're reliable, narrow-spectrum fighters. We've got the everyday penicillins like amoxicillin, tetracyclines like doxycycline, and aminoglycosides like gentamicin. Oh, and it also includes targeted drugs like metronidazole for anaerobic infections and nitrofurantoin. Basically, these are our workhorses. They're super effective, highly targeted, and most importantly, they keep the overall resistance risk incredibly low. Next up is Section 3, Watch. Proceed with caution. Now, these drugs cast a much wider net. They're broad spectrum, meaning they're effective against many different types of bacteria all at once. But you know, that kind of power, it comes with a moderate to high risk of triggering resistance. Because they wipe out a huge variety of bacteria, including our own beneficial flora, they create massive evolutionary pressure. That's exactly why the WHO target mandates that these specific drugs must be watched super closely and restricted just to specific infections. Check out how we transition from Access to Watch here. Adding beta-lactamase inhibitors to penicillins, like making coamoxiclav, broadens their spectrum, and that bumps them squarely into this restricted watch category. We also see fluoroquinolones like ciprofloxacin in here, along with carbapenems like meropenem and glycopeptides like vancomycin. These are bigger guns, right? So they require some serious stewardship.
Cephalosporins are actually a perfect microcosm for seeing exactly how this risk escalates step by step. Generation 1 drugs like cephalexin sit comfortably in the green Access group, but as soon as you broaden their coverage in generations 2, 3, and 4, think ceftriaxone or cefepime, they jump right into the yellow watch group. And by the time we engineer Generation 5 stuff like ceftaroline to fight severe resistance, we've officially crossed into the red zone.
Which brings us to Section 4, Reserve, the absolute last resort.
These are highly specific, very high-risk drugs. Basically, your break glass in case of emergency meds. We're talking strictly about life-threatening infections caused by multi-drug-resistant or MDR bacteria, pan-resistant bugs. The WHO is incredibly clear here. Avoid routine use entirely. Because if we lose the efficacy of these drugs, we quite literally have nothing left to offer the patient.
So these heavy hitters are deployed only when standard treatments completely fail. We've got polymyxins like colistin, lipopeptides like daptomycin, and glycylcyclines like tidacycline. We also rely on novel combos like ceftazidime, avibactam. These are the medications kept securely locked away, reserved for those highly specific patients where the bacteria have literally outsmarted everything else in our lower tiers. All right, shifting gears to Section 5, the post-antibiotic effect, looking at the micro-level mechanics. Because, look, choosing the right drug category is really only half the battle. You have to administer it correctly, which means understanding this wild phenomenon called PAE. It essentially puts the bacteria into a metabolic stun, suppressing their growth due to irreversible target binding or DNA damage, even when the drug is totally gone.
The antibiotic concentration falls below the minimum inhibitory concentration, meaning there's not enough drug actively floating around to kill, but the bacteria are still functionally paralyzed, completely unable to replicate.
And that leads us right into Section 6, Dosing Rules and PAE.
Understanding this metabolic stun absolutely dictates how we dose patients. On one side, you've got drugs with a long PAE, lasting an impressive 2 to 6 hours, like our aminoglycosides and fluoroquinolones. But on the other side, beta-lactams. And here's the catch with them. While they have some PAE against gram-positive bacteria, they have absolutely zero PAE against gram-negative bacteria. Literally no stun effect whatsoever.
Clinically, this is huge. Let's look at how we apply it. Because aminoglycosides, which remember are from our green access list, keep the bacteria stunned for hours thanks to that long PAE. We can safely dose them just once a day. We hit the bacteria hard with a high peak, the drug washes out of the system, but the bacteria stay stunned. This is a massive win for the patient because it drastically reduces the toxicity to their kidneys and ears that these drugs can normally cause.
Conversely, the golden rule for beta-lactams treating gram-negative infections is that you absolutely must maintain constant drug levels or those bugs will immediately bounce back. Remember, zero PA literally means zero stun time. The exact second that drug concentration dips below the minimum inhibitory concentration, those gram-negative bacteria wake right back up and start replicating. So your dosing strategy has to be entirely different, often requiring continuous infusions or super frequent dosing just to keep that drug level artificially high at all times.
I really hope this structured journey leaves you ready to make informed, life-saving clinical decisions in the war against superbugs. We've connected the massive global strategies of the AWARE framework, prioritizing access, strictly monitoring watch, and fiercely protecting reserve, right down to the micro-level mechanics of the post-antibiotic effect. The question now is, the next time you're looking at a treatment plan, how will you use this logic to ensure we stay one step ahead in this evolutionary arms race? Thanks for joining me on this explainer, and keep asking the right questions.